Thank you, Mark. That was great. So now we've got time for discussion. I suggest you leave your video camera on, and if Andrew also wants to put his camera on. We've got several questions that are appearing in the question and answer. People have been upvoting them. I'm going to take chair's privilege to ask a question first, and it's a question of Andrew, but Mark, you may have a view as well. We keep hearing about the new normal that we're going to live in after the COVID virus. How might that change the temperature mortality relationships that you're using, and how can that be brought in more generally in terms of including behavioral change or adaptation?
I think that's a great question. I'm not sure I have a very good answer to it. I think one of the challenges that comes up when you're trying to do, and I should say I'm not an epidemiologist, but I think when you're trying to do this epidemiological modeling, is that you do, this is a noisy signal that you're trying to find, so you do need typically a long data record to try and extract that signal. And so it may be that it takes some time, in that there will be behavioral change, as you say, I'm sure, and perhaps people working from home more, and that will have different impacts on different parts of the population, I'm sure. So it may be that it's some time before you can really get a good statistical handle on how that change is manifest, but obviously you can make some assumptions and change your exposure response relationship kind of to explore the uncertainty that might be associated with changes. But yeah, I think that's a great question, Jason.
Well, there's loads of great questions now coming in. The first one's from Chiara, and it's a very much a technical question on the method. Which variable are you using for temperature? Is it a daily average, Tmax, Tmin, etc.?
Hi, Chiara. We're using the daily average.
Okay, thank you. The next question from Nico. So when you're looking at the impact of the events on mortality, do you only consider excess deaths, or do you attribute to specific causes, e.g. heart failure, respiratory causes? And I'm going to ask that question to you first, Andrew, but I'd also like to get Mark's view, whether that has come up in the conversations he's been having around engagement.
Yeah, so Nico, we don't do that yet. So we're just looking at the overall mortality, and the model contains some predictors to try and remove the confounding effects, like the kind of the varying background of mortality through the year and longer term trends in mortality. There obviously are studies that have tried to do some of the things that you're suggesting, and I think they're very interesting too. We haven't done that yet, but it certainly is possible, and it's a conversation that we've had with the Met Office. As the project has gone on, one of the things that has been very useful is that the Met Office now has much greater access to mortality data sets in the UK, and so Christoph and his colleagues can pull out some of that information, and so we have been discussing whether we should produce models which have a bit more fine detailed information like that.
Okay, and Mark, has this come up in any of the engagement conversations?
Well, it is slightly different, but one of the queries that we've had was through discussion with NHS Scotland, and that was regarding the granularity that could be achieved in terms of breaking down Scotland into a number of smaller regions. And Andrew's done some analysis on that, and it's very much dependent on the amount of data that they can use to fit against their models. So we have done some work on that, because as you can imagine, users will want very high resolution or very high granularity in the outputs, and there is a limit to how far you can push things. But that's been one topic that's been picked up by a few users.
I'm actually going to ask the question from Ruth next, because I think this follows on very nicely. It's asking whether you've engaged with urban planners or councils around some of the intervention methods like green and blue infrastructure to reduce temperatures?
We haven't, but that is something that has come up, and something that we have been thinking about exploring. We just haven't managed to get to have the conversation that we've had yet with the public health authorities. But yeah, it's an excellent idea. I think we'd like to do some of that.
I think maybe we can also do some joining up within the program to the urban climate service work. So that's a nice link that follows from today. Eunice has a question, focusing on the London work and the higher resolution. Are you using the same exposure response curve across London, just higher resolution temperature, or is there scope to look at exposure response curves for different boroughs?
Hi, Eunice. Yes, we're just using the same exposure response curve across London. We did do some exploration of whether we could fit exposure response curves for the different boroughs or different regions of London. But I think our feeling is that the data set is just too small to do that reliably. So yes, we are assuming the same exposure response across London, and that is obviously a limitation of what we're doing. But it is interesting, I think, to see how the effect of the urban area plays out just through the temperature on its own, as we think about that. But yeah, it's a good question.
I guess there must be an optimum scale when you look at the uncertainty budget, as you did, and that coming from the climate model versus the dose response curve, when the uncertainty from the two matches each other.
That's right, and we haven't really explored that in any systematic way, but that again would be a very interesting idea to think about that. And obviously that is very different depending on which part of the country that you're in. So Mark talked about Scotland is a really great example of that in many ways, in that the population density across Scotland is very different. Southern Scotland has, or the central belt has high population density, but then in other regions it's very low, and so it's quite a complex interplay there between the variation in the meteorology and the number of people exposed to the temperatures in each region.
Thank you. Rutger has a really interesting question. I suspect several people are also thinking about this. How do you actually use the insights in terms of the links between the meteorology and the climate and the excess mortality? That's probably a question for both of you, actually.
Thanks, Rutger. So I guess what we're kind of imagining is that if you're thinking about, well, this is my personal view, I should say, and I'm not sure this is necessarily shared with all of the health end users, and it's a kind of part of the ongoing conversation, and I'd be interested to hear Mark's take on it too. I think my interest here is in thinking about predictions on longer timescales, and that perhaps as we've seen on the seasonal timescale, predicting some of these patterns, large-scale patterns, is perhaps slightly easier than predicting the temperatures themselves. So I think if we're imagining a kind of hybrid system which has predictions on all timescales to help resilience to climate anomalies, then perhaps predicting the events that we see in, like the sudden warming event, or a period in which we have an NEO minus regime predicted 3 to 4 weeks into the future, that might be a better way of kind of linking through to the mortality and expected periods of higher mortality than looking at direct kind of temperature driven forecasts themselves, I suppose is the way I'm thinking about it.
Mark, do you want to give a view how this might help with talking with stakeholders, how you might use it?
Yeah, so I mean, again, speaking with different stakeholders, it's clear that for some of them, there's a feeling that there's not sufficient confidence to make useful messages over those sorts of timeframes that Andrew was just describing there. Whereas for others, there's a feeling that actually might be really useful for them in terms of being able to communicate with their users and think about targeting resources and so on over those sorts of seasonal timeframes. So I think this is where it gets interesting in terms of converting that science, that understanding, and making it useful and helpful to various stakeholders. Because I think they have different levels of risk appetite, and they've got different factors that they're juggling, which means that the same science may work for some customers but not for others.
I see there's also an offer in the Q&A from a GP who's connected with a network of concerned frontline healthcare staff, offering to follow up on some of these. That might be an interesting conversation. So thanks, Matthew, for the offer. Mark will be in touch after the seminar.
Yeah, that's great. Thank you.
We've got a couple of technical questions coming up next. I'll do both of them together. So we've got another one from Chiara asking about the type and details of the bias correction on temperature. Could you say a bit more about that? But also, Suraj is interested in knowing if the mortality model uncertainty in the future plot is just for one climate model simulation.
So if I take the second one first, so in the future plot, it's for all of them actually. So it's across all of the simulations. What we just tried to do there is to show how we're kind of partitioning that out. So for the bias correction, we followed, I think it's the ICIMIP, the kind of standard bias correction approach there, looking at the kind of monthly mean and variance correction, Chiara.
And Suraj's question on the uncertainty plot, is it just for one climate model simulation, or is it including multiple?
It's multiple. It's the whole 28 simulations. Yeah.
Okay, we have an interesting question from Ruth. So Ruth's really asking about the output. What work is going on to consider what the responses or actions, e.g. of care homes or hospitals or individuals should be once they receive this information? And how do you incentivize the right responses and actions? Now, just before you answer that, again, I would highlight there's an interesting join up here within the program as a whole. So work led by Mike Davies in the ClimateCare project has already done some very interesting work around care homes and the types of intervention. They have follow-on project that is operating now, and one of the routes of output, I think, from Andrew's project here, is to make sure that data flows directly into the second ClimateCare project. But Mark and Andrew, do you want to say anything specifically around this one?
So I think obviously it will, I mean, as Mark, I guess, tried to highlight, it will depend a lot on the user and both their risk appetite, but also what they can do on different timescales. And obviously the experts there really are the public health agencies that we've been speaking to and NHS England. So my sense is that that's kind of part of an ongoing conversation. We have shared some of the data already with those agencies as a kind of example of what might be done, and then we're kind of having ongoing conversations with them about how they kind of build that into both their public messaging to ask people to adjust their behavior for cold and hot conditions, but also how they communicate to different audiences. So how do they communicate to their kind of frontline health staff? How do they communicate to social care? One example might be that with the SSW example, if you have a reasonable confidence that a cold period is on the way, then taking care of your most vulnerable members of society, those who live in fuel poverty, or checking that their heating is working, that's something that could be done on that time scale, which perhaps couldn't be done on a 2 or 3 day time scale, in terms of actually making interventions that reduce harm. So I think there's very many things that can be done, but it's all about understanding from the professionals how those messages go out and how effective they are.
Okay, thank you. There's a question asking about the impact of the demise of Public Health England. Now, I'm going to give you the option to answer that one, but the controversy involved, I think it's a choice for you whether you want to comment on that.
I mean, I really have no idea about that, Mark. I don't know whether you it's a bit of a hospital.
I'm not sure if we can add anything terribly constructive. I think it's a good point, but I mean, just on the previous question, I think it's a really good shout to have mentioned the Climate Care project, and I think that's a really good idea to engage with them. Thus far, the decision was made on the basis, largely on the basis of our previous experience of developing services for the healthcare sector, that we should stick with the main organisations that I mentioned earlier. So those have been our primary focus. I think the points raised about how this gets pulled through to decisions is really at the heart of how this pilot climate service gets embedded and implemented. And I kind of think we need to be mindful of the scope of this project and any follow-on work to embed and deliver in a routine fashion, and the subsequent dissemination is a bit of a slightly different question.
Thanks, Mark. There's another very interesting point from Chiara, noting it's interesting to be able to actually see a signal 3 to 5 weeks after a sudden stratospheric warming in the UK. Do you want to say more about that, Andrew? Because I know you're working on a paper on that.
Yes, it's about to come out actually. So yeah, I think it's kind of an example of how the different lags in the climate system and health system are to our advantage here. So we know, one of the reasons why we're interested in stratospheric sudden warmings in terms of winter prediction for the UK is that we know that they tend to be followed by cold conditions for some periods. So they're one of the drivers of the climate system which have long memory and tend to give us the opportunity to forecast them. And because the impacts of that cold weather also have a long lag, it means that actually the impacts of the cold weather associated with the SSW, as you say, occur sometime after the event itself. And so that really does give an opportunity for taking advantage of those events as a tool for for reducing harm effectively.
Thank you. I think we'll just have one more question. It's another one from Ruth, and she's asking, overall, will heat cold related deaths increase or decrease in the future? So I think it's taking that that big picture view when you take both ends of the curve into account.
So I think both of what we've done here, but obviously there are many other studies which have tried to look at this in some detail. I think it's clear that hot weather deaths will increase substantially, and cold weather deaths, although the number of very cold days will decrease, there are a number of studies which have looked at how that is influenced by changes in demographics. So if vulnerability stays the same and the population ages, then actually we might expect a rather similar number of cold weather deaths, even though the weather itself will be perhaps will be milder. So I think that there will be challenges at both ends, both in winter and in summer, as we over the next 30, 50 years or so.
That's fantastic. So I think, again, let's thank Mark and Andrew for the wonderful talks and the really interesting discussion. Susie, can you bring up the slide for the next of the seminars briefly, please? So it's useful just to highlight, this is an ongoing series of seminars. The next one is on the 21st of October. Declan Conway will be talking about adaptation to climate risks in the UK wine sector. On the 28th of October, we have Robert Nichols talking about coastal resilience to flood and erosion hazard. So please join us for those, and also note the slides and audio for today's talk will be available on the website. Thank you very much, everybody, for joining.